My name's Larry Downs. I'm the CEO at the Medical Society of New Jersey. And our president, Dave Swee, is on vacation this week. So I'll be kind of hosting you this evening. And welcome to our first installment of our 2025 lecture series. And we're happy to welcome Michael Ruiz Somocurcio, the president of Vytalize Health Independent Physicians Associations in New York and New Jersey. Mike leads this is actually the largest IPA in New York, called IPA NY. It's comprised of over 3,000 providers. The group has over 20 health plan agreements and 150,000 attributed value-based care lives. Prior to this work, he was at Aetna, where he served as the chief network and operations officer for both New York and New Jersey markets. That market was Aetna's largest, with over 20 billion in annual spend and over 3 million members. He's responsible for developing the overall network strategy, management of medical costs, creation of new products, and value-based care initiatives. Overall, Mike has a 20-plus year career in healthcare, working on both the health plan and the provider side. He actually was involved with RCCA, one of our large group members, when I met him. So he certainly has experience on medical practice as well as payer environments. He has actually been developing innovative and collaborative solutions to improve the overall health system delivery for a number of years. He's a good friend to MSNJ, and I thank him for being with us tonight. So let's jump right in, and I'll turn it over to Mike for his presentation.
Awesome, Larry. And thanks to the Medical Society of New Jersey. I've been on both sides of the table, as Larry has mentioned, and the Medical Society has always been a really strong partner, no matter where I sat. So it's really a testimony to Larry and the rest of the association's work on supporting the physicians in the state of New Jersey. So thanks again for having me. You did a good job, Larry, of my background, so I don't need to go about that. So fantastic. But why am I really here today? I guess it's the business of healthcare is really tough, I would say, for physicians. If you look at even just what's happening in 2025, there's declining reimbursement on the CMS physician fee schedule. So you can see the numbers decreased by 2.6%. This in an environment where costs are increasing. And you saw this in COVID specifically, but the costs of running a practice, supply costs, by CMS's own estimates, that looks to be 3.5%. So when you look at CMS reimbursement being lowered by 2.6, but CMS also estimating costs are going up by 3.5, that's a 6.1% shortfall for a lot of practices in an environment like that. I will say I come from the plan side prior to this role, and health insurance costs are increasing dramatically. I've pulled some New Jersey specific slides later that we can walk through. MIPS is a real thing for practices, and the penalties have increased over the years for those who are considered underperforming, while the high performers, the average bonuses are a lot less than they were historically. So you can see CMS is really trying to push folks toward high quality, cost-effective care, and maybe doing it at a pace that maybe the population may not be as ready for. I will say what you see sometimes is plan policies and audits can disrupt the cash flow of a practice, making it difficult for outlays of investments into technology or data or analytics. And from sitting on both sides of the table, I would say, like, when you look at the overall system, and plans have to take some responsibility for this as well, along with hospitals, but the system is almost really stacked against independent physicians. There is a lot of consolidation, which I'll talk about in the market specifically in the next couple of slides. But normally a plan standard fee schedule is going to be below Medicare. So if you're not looking at that, not looking at your renewal dates, kind of taking what's offered, it's gonna it's a real financial bind that could happen for practices who aren't looking at this, and that's why we're having this discussion today. I did mention an overview of what's happening in the marketplace, and this is really important, I think, of what you're seeing. And, this is a New Jersey function, New York where I'm at, but also a national kind of phenomenon. But you can see here on this slide, the amount of physicians who are considered employed. That could be employed by a hospital, and we have a lot of that in New Jersey. It could also be employed by a corporate entity. So when I was at CVS and Aetna, we had purchased Oak Street Health, which is a clinic. If you look at Optum purchases practices, they're included in this number as well. So that's a United company. But you can see even from, I would say 2020, the pandemic started, 65.8% of physicians at that point were being employed. You look at it into where January of 24, we're up to 77.6% overall, right? So when I look at this, it's really difficult maintaining an independent practice. So folks are saying, hey, and also the financial dynamics of the system, which we'll talk about a little bit later, of why it's attractive for maybe some hospitals to purchase physicians. I will say, and I pulled this from PwC, they always do a really nice cost trend report, but you can see this is an environment of medical cost trends continuing to increase. And it's really every year, so you never see cost trends actually below zero or negative. It's the only industry where innovation actually seems to increase costs in healthcare. But you can look overall at the path of what this graph is that, in the group or individual marketplaces, so that would be ACA, that overall you're seeing medical costs increase for 25. The estimates are 8% on the group employer business, and then 7.5% on the individual. So, when you think about like a family health plan, estimates are cost $20,000 for a family for coverage. When you're looking at, it's almost a never ending cycle of this increasing each year. Like, when will those increases end? And some of the drivers are things like, inflationary impacts. So when you look at COVID, there are a number of providers and hospital systems that are asking for maybe higher increases than they had historically. The cost of labor had gone up dramatically, again, for the providers on the hospital side for that. GLP-1s are an amazing drug, absolutely amazing. That's changed actually a lot for the better, but there is a cost associated with those benefits for that, and that's hitting a lot of drug costs and employer cost as well, and then behavioral health, the continuing rise of that these days. New Jersey, listen, New Jersey's got a couple of things that are, that I like a lot. The best pizza around, the best bagels, but unfortunately they have some of the highest, some of the highest like healthcare costs in the nation. You can see this was in 21, so it's a little older, but this was just a report released by, and the links are all here. It's a really interesting review if you guys can look at this, but you can see like spending trends, and this is in the commercial insurance market, but you can see how the commercial insurance market over 5 years had gone up dramatically. And you're really starting to see, I would say this slide, if I were to extrapolate what the state will show for 22, 23, 24, 25, it's coming up this direction for sure. It's not like it's changing at all. So you can see the numbers there. So in a high cost state, obviously there's a lot of focus on, hey, what are the opportunities to look at? What's the value prop? And I wanted to give all of you guys a background of what you were seeing in the market to then show you how there's real opportunity, I think, for practices who can have a conversation with plans. The last slide I did want to show, again, publicly reported information, but I wanted to show where some of the dollars flow here too. So this was, again, it was part of this RAND study. So this was done by the Healthcare Cost Institute and included a number of different plans. But you can see the pricing of hospitals in New Jersey. Now, I will say, because I sat on the plan side, I highlighted some of the ones in yellow. Those are the CarePoint hospitals. Those numbers are going to be different today. These numbers were at a time when those hospitals were, out of network per se. So there weren't in-network deals that the plans were doing. But so when they became in-network, these rates are going to lower. And that's a function of the marketplace of in-network deals versus out-of-network. But this just gives you a sense. But the other ones you can see here, they're all, all really large systems in New Jersey. Obviously, like when you look at commercial rates like this, the point of this is that Medicare and Medicaid in the state, there's an argument that they're not paying for the cost of these services. So unfortunately, the commercial market bears this out. These numbers are from 2020. If I just did like simple 5% increase, on the first one here, so the 289 Virtua, if a 5% increase each year since 2020, that brings this number to like 350. So hospitals, do a great job. I partner with many of these hospitals, but it is a higher cost setting. I think some of the things you are seeing with these hospitals, though, too, is over time, certain, lower cost or lower acuity services are being pulled out and done in more of an outpatient setting. So there is an argument to be made that, hey, there's a higher level of acuity happening in these hospitals, but this is the going rate for commercial insurance in the state of New Jersey. It's very, very expensive. So this goes to the slides before about why you have a 15% cost situation, or maybe the state of New Jersey talking about looking at growth caps. All at Aetna, when I was there, 85% of Aetna's business was actually self-funded, which means Aetna was not at risk for those claims at all. It was, in essence, funded by the employers of the state. State of New Jersey, very large self-funded employers. So this gives you a sense of, what the financial dynamics are. It's very different when you look at physician pricing, though, for sure. So I just gave you guys a ton of bad news. What the heck am I going with this presentation? But I will say that in an environment of increasing costs, there is opportunity to provide a lot of value just to employers and plans if you're able to look at cost-effective, high-quality settings. So when the biggest thing about speaking the language are here are the things that really drive plans, when I look at this. So, obviously, like medical cost management, there's important focus on that. And that could be your network price. Maybe they'll look at vendors, they have authorizations. Site of care is really important there, which we'll talk about later on. And that's simply like, if there's a lower cost option, same quality perspective, why have that service done in the highest cost setting? Right. So that the plans are mainly focused with, because like I said, 15% of the business, they're on the hook for all the risk for it. But for 85% of the employer business, those employers can shop and go to any health plan they would like. They're focused on who's got the best potential price in a high price market. HEDIS and STARS performance really key and critical here, because a lot of the plans are graded on this, for Medicare on STARS and HEDIS and quality. There is components of reimbursement that are associated with that if you do well. I will say there's a movement toward value-based care, and that just means like managing the total cost of care of what's considered an attributed patient, right? They are looking at different networks. So, Medicaid may be more of a narrow network normally versus a commercial network, which could be broad. Plans are developing some of these products. You can see whether it's like an Omni at Horizon or at Aetna, we had an all health product where they may be creating some sort of narrow network approach for a lower price point in the market. So they are interested in developing multiple different resources and multiple different networks for their, for employers to choose from, right? Coding accuracy is a big thing. That impacts premium. That has to be done really carefully and compliantly. And then the member experience, I would say. And I think what I always knew is like, if I was reaching out on someone on behalf of, let's say, Aetna or any plan, the patients would be less likely to pick up the phone if they saw that the plan was calling. If they saw that the provider was calling, they'd be much more likely to pick up the phone. So I think when you look at a member experience, that's kind of been clunky, I would say, maybe from a health plan perspective. So they are looking for help with that, whether it's with the providers or maybe, there's a number of navigation choices, but they really want to increase that NPS score, which historically for health insurers has been very, very low. And if anyone has any questions, I mean, Larry, it probably makes sense maybe do questions at the end. I just want to, you guys.
Yeah, Mike. Well, if you have a burning
Okay.
question, raise your hand, but we'll wait till the end and have a little Q&A. So go ahead.
Okay.
Mike.
Awesome. The biggest thing now, we're starting to get into like, that's all the background. Now it's like, okay, well, you're going to start to say, look at your deals. We'll talk about that in a little bit, but You got to know the plans. You have to know the market. Be really, really clear about like, okay, what are the maybe struggles of a health plan, or what are the opportunities with a health plan? So, these are the three biggest plans. I didn't include some of the others, but Horizon, the largest plan in the state of New Jersey, very large networks, very different the networks too. So for Medicaid, I think they have every hospital in the state. You don't normally see that for Medicaid plans. They have a robust ACA plan. When you look at their MA network, their MA network is going to be very different than what UHC's MA network is. MA network is really Braven, and her HMH is a large owner, and RWJ. Those are two health systems that are owners, a joint venture owners of, in essence, Horizon's Medicare network for the state, right? So they may have some different focuses that they want to look at versus maybe some of these other plans. I will say, which I'm appreciative of, Horizon does look at in New Jersey the independent practices, and they're really looking at trying to support independent practices. So they did announce a JV with Deerfield Management. It's early, so it's early in that process, but it's an opportunity for practices maybe to aggregate together to be able to do value-based care efforts. So we'll see where that goes. But again, that's another opportunity that's been coming to the state. Aetna, again, very different carrier, different focus, right? So, they have their own truly narrowed, network options. Their main owner is CVS. Some people actually don't know that, but CVS owns Aetna. CVS Minute Clinics are integrated within their network options now. And then the pharmacies, which, there's been a lot of pharmacy noise, I would say, when you look at Walgreens and Rite Aid, but CVS pharmacies have been pretty consistent. And the idea is, how can you focus more care on the pharmacies through the Minute Clinics, but how do you integrate that within a network approach, right? And then largest MA membership actually in New Jersey when you include group. So they have the state of New Jersey retirees as an Aetna group. And lastly, UHC, very different, absolutely different than them all. UHC actually owns a number of providers. So they own Riverside in New Jersey. They have an IPA. In New York, they own a number of practices, Caremount, ProHealth, Crystal Run, all good practices that know how to manage populations. So they pick them really well. Their model seems to be very different than our hospital model. So they also are owners of SCA, which is a freestanding ASC network, and then some narrow networks here. So their approach probably is to focus on their owned providers mostly, but I think they're going to have a focus on independence as well, because they see the value of independence just based on some of these. So if you're an ASC trying to get into network with United, I think it's probably going to be tougher because they already have a group of ASCs that they own in the state. So this gives you a little background of that. Now, a couple big things to get into of like what plans employers like. And we kind of touched on this before, but I wanted to lay it out here because this actually goes into the value prop you could create when we start developing proposals. Okay. So all of these, and I call these physician choice decisions, but very meaningful and value-based care deals. So you have two options. Sometimes it's, hey, I can refer people to, I'll just, in where I live, there's 5 hospitals in Bergen County. They all do imaging. I live in Oradell. There's New Bridge Imaging. I think that's what it's called. New Century Imaging. That's literally like 2 blocks away. New Century Imaging is probably 1/5, 1/4 of the cost of a hospital scan. Quality's strong, is good. So that's a decision. If I'm a physician and I refer into more cost-effective options, the way value-based care deals work is that there's opportunity to potentially share in those savings, right? And that's a really important concept, which we'll touch on later. But if I look at any of these decisions, is a low-cost option, a high-cost option. There's also member convenience. Like maybe it's more convenient for members to go in certain places versus others. A lot of products right now have co-insurance or co-pays. So if a member has co-insurance or deductible, there's an incentive for the member to also look at the low-cost options. Again, if there's no difference in quality or access or whatever. So there's a lot at play here that actually could be beneficial to consumers, plans, employers. But when you look on, I would say it's the left side here. So, LabCorp Quest, versus some boutique or hospital labs, much more cost effective. I think also like there's a lot of integration that occurs between, certain labs and the health plans, which again help to identify gaps and other things. Health plans see a lot of value in that understanding that. It also helps with HEDIS metrics and other quality components. So having that alignment is good from a cost perspective, but also good to find gaps in patient care that could potentially be happening. We talked about imaging. When I look at, drugs are very, very expensive. If there's an opportunity, and most plans, I would say for the most part, have different rules or formularies and step therapy, whatever you may call it. But traditional Medicare doesn't. When you look at this again, generics, biosimilars versus brand, if there is a comparable option and it's a lower cost and members have a donut hole or out of pocket or any of that stuff, there's an opportunity for patient savings, but also for the system to save there. One of the things when I was, Larry mentioned I was an RCCA, and one of the interesting things we saw there was, listen, it's a cancer group. So it's the largest group of oncologists in New Jersey. They, what they would see is like, and this was for almost every hospital really, but if an oncology patient showed up in an ER at almost any hospital in New Jersey, on average, between like 70 to 75% of time, that patient that would show up in the ER would actually be admitted to a hospital. Okay. And probably various reasons. Sometimes they may have been really sick where that makes sense. Other times, a cancer patient looks sick, so they're going to be sent upstairs. The difference, for Medicare between an ER visit and inpatient admission is probably like, from $1,000 to $25,000 for an inpatient admission. So it's really key and critical that, really things that can be either done after hours or in a minute clinic or in an urgent care go to those settings versus ER. Because what happens is if they show up in the ER, there's a high likelihood that people are going to go upstairs, and that's much more costly always. But that requires management. I will say like ASCs, obviously that's versus hospital, again, very large cost differences. Infusions, when you look in New Jersey, the impact of 340B pricing with hospital acquisitions. So it's really profitable for physicians or for hospitals to acquire physicians who give drugs. So a physician may have been giving drug in an office, get paid at 100% of Medicare. They get acquired by the hospital. They give the drugs out of the hospital, tax ID. Those drug costs are very different than they would be in a setting that's done in an office. So there is a lot of value for physicians, to plans and employers, for physicians that are doing things in an office setting for sure. And what you're seeing with some of those physicians, again, RCCA being one, the rheumatologists, they are creating their own kind of pharmacies as well. And then the last thing is just really addressing the gaps in care and any preventative metrics. Those are important. So at the end of the day, like these types of decisions are very meaningful to plans. And they will look at their data to see like, hey, if we have a discussion about either a rate increase or value-based care, if you could say, hey, I do these things, it really makes the case much, much stronger because you're really speaking their language, which we spoke about before. Okay. Sorry, hold on. Okay, now we're ready. You're ready to go. It's go time. Now we've got some work to do, right? So the biggest thing is, you start looking at your contract. You have to pull it if you're a physician practice. When is the renewal date? Sometimes it could be like an evergreen. Evergreen status just means, hey, the deal is live. It keeps going until a meteor hits the earth or the end of time. Unless you say, hey, I want to renegotiate or I want to terminate or whatever you want to do. So most physician agreements, I would say, are evergreen status. The other type is a hard stop. And you do see a lot of hospitals that have hard stops. So, you may see in the news, and there's one right now going on, a termination between Horizon and the hospital system, and they're saying, hey, we're terminating as of this date. There is a hard stop in that contract. That means unless there's an agreement or an extension or something, the contract could just end. And without an agreement, the state does require notification provisions. So it's important to know that. The other thing you see sometimes in deals is that it may say, okay, well, the deal renews every April 1. You have to tell us by January 1 that you want to renegotiate or open the deal. And if you don't tell us by January 1, then the 4/1/25 renewal date is locked until 4/1/26. So you have to know that that could be a year wasted time. I've seen deals like that, right? And so it's important to know when those are and prepare for it, because you don't want to get stuck of saying, hey, I really need an increase here, or I really need to have a discussion. And then all of a sudden it's like, well, I have to wait another year because that's what my contract calls for. I will always say, like, pulling a report, and this is pretty easy. Most of you can do this from your own systems. You do have to segment it out by product, right? So sometimes on the health plan side, there may be different people that negotiate Medicare, commercial, or Medicaid. Some plans actually have maybe one person doing commercial and Medicare and maybe a separate person Medicaid. But it's important to segment that out correctly, but also do your analysis correctly, so you have an accurate view of what's happening for each of these product lines. These are important numbers here, like units. The charge amount, not so much, because charges are whatever anyone likes them to be. But the allowed amount and paid amounts are important. The allowed amount would be the total paid, like in essence, the contract rate, which would include the member share. And then the paid amount, in essence, is the amount that that doesn't include that. So it's the true plan payment, not including the member, or not including the member share. So you want to know both of these numbers, and the reason being is that sometimes what you'll see is that, especially with like co-insurance and high deductible plans. I mean, the ACA deductible plans are probably like over $7,000 in New Jersey right now. So you want to be able to see like what the true number of collections is, and what may be, because of the co-insurance plans or deductibles, what may be like outstanding from a balance perspective. And it's really important to know that, because you can say, hey, my deal's 100, I'm supposed to get $100, but because members aren't paying their collectible portion of it regularly, or because of denials, or because of billing, edits or down coding, I'm only achieving like, 90% of that. That's something that you really need to bring up as part of the discussion. I think one of the things that I'm seeing nationally right now is a lot of pushback with MA plans. So there's, you're seeing like, and this is all public information, you're seeing scuffles between hospitals or provider groups and health plans as it relates to participation in Medicare Advantage plans. And some are saying, hey, we don't like the authorization protocols and the audits, so they're going to pull out of participation. Others, are working collaboratively with plans to look at like, hey, how can we streamline some of this, like, in essence, industry inefficiency, I would say, in the back and forth discussions. So it's always really important to know, like, what's happening here. And is it a payer that, is a strong partner that's willing to work with you? Or is it a payer that may not be available, to answer questions, or may not be open to fixing issues? You do see that certain payers are more willing to work with you than others in certain markets, for sure. I will say, certification is important. You do see, and this could be pediatric practices or PCMH practices. Having that designation it's not easy to get. It's a lot of work, but it's an important function and a differentiator in the market to show the value of a practice. They're doing some of the things I mentioned before, navigating patients to finding care, that they're plugging gaps, they're looking at behavioral health. They're looking at advanced directives, right? So these are all like important concepts, but having that designation is really, really, I think, key and critical here overall. Here's, it's funny, I just posted something on this on LinkedIn the other day, but transparency data is really becoming widely available very, very cheaply. Like you could probably purchase like, maybe $10,000, a review of New Jersey providers just by some data aggregation company at this point. I just saw President Trump, was basically like pushing, compliance of the, Price Transparency Act. So basically what was happening is, there was a requirement that health plans have to post all their pricing. There was a requirement that hospitals have to post their pricing. The interesting about this, when you go online, you can actually like go to the websites and, it's hard to find them, but you can find them. But when you find out where they are, and this is on the plan and the hospital side, so I want to be fair, both stink right now. But if you go in there and look at it, if you click on it, it shows up as a machine readable file. There's no way you can even figure anything out with it. If it's a machine readable file, that means a machine has to actually review it, provide insight. So there's no value to consumers for this whatsoever. The only people really looking at these files are consultants, who are probably creating solutions to show this. Health plans look at it too, because they're now saying, hey, is my deal better or worse than these other plans? Hospitals look at this 100%. It's come up in many negotiations that I led on the plan side. And they're saying, hey, you're paying this hospital 20% more than me. Where's my 20% increase? I never had the argument come from like, hey, you're paying me 20% more than the rest of the market. Where's my 20% decrease? That never happens, right? So the way the transparency files were kind of working in practice, from what I saw, is that in essence, it was almost as creating a price inflation, because if members can't see this information, but only those who are in the industry see it, it's almost being used for that type of effort as well. So it is important to see, where you're comparing to other providers in the marketplace, to other health plans, looking at the going rate, but also to know like there is a hospital physician fee schedule will be higher. It just will be higher, right? Different costs associated with it, different negotiation, different leverage. So there is value of being below those higher fee schedules. The question is like, hey, where do I stand in the marketplace? And can I make the argument that, based on all the other things that we talked about, there's opportunity for me to do things that way. So this is really important. So I do suggest, to look at those, this type of data. It's going to be really helpful for practice to understand what's happening. All right. Jerry Maguire was one of my favorite movies. So it's proposal time. You can't just run in there saying, show me the money and you're going to get an increase. Doesn't work that way with the plans, right? So we'll talk a little bit about that. But I will say that, when you look at the standard plan fee schedule, it is low. It's very low. So your plan standard fee schedules for most plans, I would say, are going to be somewhere between 70 and 80% of Medicare. And that's on a commercial marketplace, right? So a commercial marketplace on the standard with, if you just, sign a contract that a plan gives you, in essence, that's what it's going to probably look like. And some codes could be higher, some codes could be less, but for the most part, that's what you're going to see on that. You'd be surprised at how many physicians actually, take that fee schedule. They just want to see their patients. They want to do their business. So that is the rate there. And what you can see before, what I showed you of, some of the percentages of CMS for hospital services, obviously much, much larger than that. So you can see where the difference is. It's very, very large. Before we let all of you on the call, Josh, Larry, myself, we're talking about Medicaid in New Jersey. And unfortunately, it's like abysmal. It's one of the lowest in the nation, actually, especially for primary care. So I know the good work of MSNJ. I was working with the Quality Institute. There's a talk about, hey, how can we strengthen the primary care payments for Medicaid, because it's because the fee schedules are so low, the access of people actually accepting Medicaid is also low. So it's become a twofold problem here. And the last thing I do want to mention, like when you look at 100% of Medicare, so let's just say it's a very reasonable proposal. I want 100% of Medicare. If you have, $1 million in spend with that plan and you want 100% of Medicare and you're at 80% of Medicare, so basically that's like a $250,000 increase for that plan's budget. So, we'll talk about strategies around that, but that could be the case. And you can tell from your own data what potentially that looks like. I will say simple is always better in a proposal. Rather than proposing like carve outs, you really want to have a flat percentage. The reason being is that if you grow or specialize in other things, you don't always have to be negotiating like carve outs. And keep in mind, like the plan, they do like budget certainty. So, and they also don't want to be renegotiating all the time, right? So like, just give you an example, a standard deal with the hospital, maybe 3 years. And there's a reason for that. The plan doesn't want to continue to negotiate. It's a lot of work, taxing work, and the networks are always moving. So there's an opportunity for that too. So it's, they don't want to keep going back and forth, back and forth. So you have to be really strategic so that it doesn't occur on that side of the house. We mentioned this before. So how are you handling those physician decisions? When you send a letter to them, I think and I would always be open to this when I would see these, but when I saw a physician saying, hey, listen, I have a freestanding ASC and all of my, the anesthesiologists are part, the pathologists part there, or I have after hours 3 days a week, and I don't have, my answering machine doesn't say, hey, go to the ER right away. It says, call me and come in right away, where you have after hours access and an openness of that. Or I have PCMH designation. These are all things that would show value to me right away of saying, you know what, this practice is doing things the right way. It makes sense to support like this practice, again, maintaining their independence and being successful. The one thing I will say though, is you have to know your leverage. So I saw scenarios where sometimes a group would say, okay, take it or leave it. I'm leaving the network, but they don't really mean they're leaving the network. And a lot of times if plans have a lot of a specialty, they may say, okay, well, best of luck, you can leave the network. So you do have to know, like, what types of services are they? What, is it a plastic surgery group? There's not that many of those that are in network in New Jersey. They have more leverage. Is it a specialty that, is only within, there's only one group within a certain county? Like including that in the proposal is really important too. But you also have to know that, if there's a lot of that specialty or provider type, the plan may have different decisions moving forward. I'm not going to spend a lot. This is just an example of what you see on some of those. I talked about the data showing different fees by health plan. So this just gives you an idea of what that looks like as a dashboard. I want to spend a few minutes on value-based care. So I think, sometimes there's opportunity to do fee-for-service deals, and in addition, have opportunity for value-based care. This is, revenue diversification, revenue opportunity. It's not free money, so it's not easy, but I think it could be very meaningful for practices. In our IPA in New York, we've been able to distribute meaningful dollars to practices based on our performance in value-based care deals, and whether that's Medicare Advantage or commercial or Medicaid. We've kind of built a framework where we can perform well in some of these deals, from a quality scoring side, but also on the cost side, to where then we're able to distribute. So if you're a PCP practice and you're into these deals, and let's just say, your take-home pay is $250,000 a year, and you're able to get $50,000 in some of the, based on the performance you're doing here, that's a 25%, or 20% increase, on your salary for the year. That's meaningful dollars. And there is opportunity for that, whether you're a pediatric or PCP practice. There's opportunities for specialists as well. But I will say the key is attribution. So you have to have enough to enter in these deals. And unfortunately, what you see with a lot of independent physicians is they don't have, that much attribution to qualify on their own. So they're pooling together in like a clinical integrated network or potentially an IPA that we have. Those are options. But what I always recommend in practices is, you have to explore those options. It could be a creative opportunity for the practices themselves. In New Jersey, I think Horizon was a big proponent of some of the specialty models. You don't see a lot of specialty models happening as much. It may happen like ortho or kidney or oncology. Those are the main three I still see, but specialists do have a very large place though in your normal like ACO attribution type of models. And then lastly, when you look at ACO REACH or MSSP programs, both of these do provide MIPS exceptions. That's really important. But you do see some enablers that are providing enhancements to PCP so participate. So we do this, companies like Aledade, Agilon's another, Honest Medical, Pearl Health. Those are companies that for smaller practices who can manage populations, there can be a lot of value added to those practices too. So it's, again, important to look at overall, like the strength of a medical practice relies on a number of different things. It relies on, the fee for service component has to be strong. If you can, add in some of the value-based care, and whether that's on the health plan side or the care programs like MSSP and ACO REACH, or Kidney First, or these other types of models, like when you add those three components, there could be really meaningful overall for a practice. Okay. So advice from a former health plan lead. So, a couple of things really quick, and I do want to make sure we have enough time for questions, so we're coming up on that. But the one thing I will say that's different, it's funny, now I'm sitting on the other side of the table on the provider side now, the provider relations at plans have definitely lessened. So, they are looking at moving more towards self-service, so like Availity or Navinet or their online options. So it's tougher to actually get answers sometimes than it used to be, I would say. The main contacts, often, their job is to kind of say no initially, and that's really a function of, there's a number of requests coming in, and you have to be selective about which ones make the most sense, right? There has to be a case made for a number of these based on plan budgets. So the idea, really, you have to work with local network leadership. And when I say that, like developing relationships or attending different events, it's really important to understand the network leads who may have a more strategic view than the contracting rep or the provider relations rep would. That's important. The last thing in this section, I think it's sometimes we get a lot of pitches of like, hey, we can do a cap deal, or we can do, we'll do a prospective payment. We'll shut off claims, then you'll give us a payment up front, and then we'll reconcile in the back. Like plans are, they're legacy systems. They're not flexible. When you're proposing things like that, it's not going to go far, because again, there's a million things that a plan has to focus on and look at, unless it's within something that's like, hey, we're going to do an ACO work, and the plan's developed like an ACO program specifically. There are negotiable items there, but you're not going to be able to build a different type of ACO program, because again, the way the plan's set up is to make sure they're automating and running scripts based on the programs that they have. So just be really mindful that these are big entities that cannot move fast. So, when you're proposing something, I always like to make sure it's within the framework that they have, and that I'm not trying to create a different framework, even though I may have worked on that side. I will say, like, having someone skilled on your side is absolutely key and critical, right? The plans have a lot of data, and they see things outside of your practice. They may see, they're seeing where you're submitting lab results to, and imaging, and which specialists you use, and which hospitals. You do have to have someone on your side that understands these concepts, right? And it's important that When I was, I was recruited into RCCA, they were getting many deals pitched to them, and they're, my boss at the time was like, hey, we don't even know if any of these are good deals. We don't even know what to ask for, so they hired me. I was a plan person, right? So I was their in-house person. You don't have to bring someone in-house for that. There's numerous consultants that have relationships in the market. They also know how to do this negotiation work, and also even IPAs. And, we are launching an IPA in New Jersey. That just started for us, but there's multiple other IPAs in the state too. So it's important that you have folks that could deliver upon this value. And, like I said, it could be the 3 different options depending on what works for your budget, but all 3 options work. Now, I will say that the plans have budgets, and, if you look at the financials of health plans these days, that's very challenged, especially in the Medicare Advantage environment. How plans work, some inside baseball, they do set their budgets annually. So every year that's an annual cycle. For the most part, they're putting the largest providers in, and they'll say, okay, we have a budget for this hospital of this, all the large groups. And usually it's like, maybe it's if physicians or ancillaries over like $500,000 in spend annually or something. And they will have numbers associated with all of them based on their position in the market, historical estimates, where they think the market's going. So all of that's important because that's how the plans set up their bids. They may set up their bids for Medicare. They may set up their estimates for pricing for employer group markets. So it's really key and critical that people understand that the plans do have living, breathing budgets, and they do want to meet their budgets, and I would imagine the budgets this year are going to be very challenged for a number of these plans. Now, if you're a smaller provider, you're going to fall under that. You're not going to have your own line in the budget. You're going to be in a catch-all bucket. But again, that catch-all bucket also has like hey, we have an overall number we want to look at here too. So just keep that in mind as we're doing that. The last thing I will say is when you look at your deals, you want to be persistent. You want to be respectful, but you want to make sure you're persistent in that you're following up. Sometimes there's a long cycle to these deals. It could take like 6 months to negotiate a deal. It could take a year to negotiate a deal. You want to be patient but persistent, right? Like, hey, I'm following up here. Was there an update on this proposal? I always like to, and this is what I said in the beginning, simple proposals don't take a long time to review financially. If you make it a complicated proposal, it's going to take way too long to review financially, right? And again, that goes to like the timing of the overall proposals too. So always, follow up, be persistent, ask for updates, but know that again, that these are monster ships sometimes that take a little while to move. If you're not getting a response, I would always want my team to be responsive. If you aren't getting responses, I think you should, there's no reason you shouldn't be escalating some of these, negotiations or deals, with the right folks that we talked about before. The other thing I will say is it'd be nice to say, hey, I'm getting paid 20% below the market average. Give me a 20% increase in year 1. Like normally, again, the plans from a budget perspective have to set these budgets out. So you may not get everything you want year 1, but it's not it's always good to show flexibility to say, hey, can we achieve some of these over a few years? And whether that's like, the fee for service increase, or just say, hey, listen, I'll do an upside value-based care deal in year 1. Maybe in year 2, I'll take, half downside risk. Year 3, full downside risk. Like it's okay to have a glide path for these, but I think the idea is, strengthen what you can on these deals and make sure you're getting value for all the value that you deliver. Because at the end of the day here, what I will say is for all the reasons I laid out today, independent physicians continue to be the best value in healthcare. When you look at what's happening in the marketplace from a consolidation standpoint, what's happening from a hospital pricing standpoint, and what's happening from employers continuing to get high premium increases, that I do feel like there's been a focus in the market either on direct to employer stuff or plans creating some sort of these value-based care focused networks that there will be a focus on value for employers and plans by, working in conjunction with the independent physicians in the market. And that's it. So I want to thank you for your time. I am open for questions.
Mike, thanks so much for those insights. And if you do have a question, just use the raise hand button and we'll recognize you. But not seeing one yet, I'll start. So in my work, I've noticed that you're not even small independent practices, but even the large groups, large OBGYN groups, having a really difficult time negotiating, anything more than a 1 or 2% increase year over year. And we know that the inflationary burden that you pointed out is over 3% a year. So what would be your advice in terms of how to escalate some of these for a small practice that might be dealing with their provider rep and person always says no? What's the best way to escalate that, or what would you suggest in terms of giving some practical advice about how to move up to the next level and get past that no and get a real review of your proposal?
I think there is a kind of an org tree in every organization, right? But I do think helping to focus on, whether that's the director of the team or the vice president of network. I mean, you can find these names. They are local. And I think what I'm seeing is certain plans maybe, it's funny, like a health plan, a network contractor lead for a market, in my mind, is such an important role. Because when you think about like that one role with the plan, literally almost controls kind of like the pricing of the entire market in a way, right? So it's funny sitting on this side. Sometimes I'm a little frustrated in it because I'm like, well, isn't 110% of Medicare for an independent practice who does everything that we talked about a lot better for you than 150% of Medicare for if they become hospital employed? There is some, there's some sort of planning in the market where you have to kind of say, hey, this is what's happening here. We already have 77% employment. I think it's really key and critical that they have to talk to the right folks at the plan who may have a broader view of where the market's going. Sometimes, the provider relationship may not know, like, well, the entire state could have different pockets of what's going on. So I think that's important. And then if you're a maternity provider that's controlling a lot of deliveries, I look at certain VBC models for maternity that historically have been done. I think that's another avenue. But you have to do both. And I do worry about deals that are just VBC focused without focusing on the keeping the lights on type of thing too. I think you're right.
Thanks. And I do have a question from Dr. Lamb. You have your hand up.
I know Derek. Hey, Derek.
Hey, Mike.
Some of my friends are on this call, actually.
A long time. And I'm not a doctor, but I had a question for you, Mike, about what do you think is a good way to think about for practice of, from small independent practices to larger provider groups, in terms of a strategy for the term of a contract or the length of a contract? When should you be looking for an evergreen? When should you look for a shorter deal, like 1 or 2, 3 years, that sort of thing?
I think it's I don't mind like 3 deals, but I would say for a practice, you don't want to get in the scenario where the contract has a hard stop. So, I get it for hospitals because, there's notice requirements and other things. So that makes sense to me, like hard stop of language. But for a smaller practice, you don't want the clock to be ticking and there's not a lot. It creates a lot of member disruption. So I think an evergreen deal makes sense for that. What I would suggest for a small practice though is, if it's, hey, we're getting a 1-year increase in the deal, then do a 1-year deal. If they're willing to do it over a few years, then I think that certainty is better, because at least you're getting something locked in, overall. But yeah, I think you got to kind of let the deal flow where you're being presented to as well, right? And take what you can, the bite at the apple, the best you can get. Sometimes it's a 1-year deal where they'll say, hey, we'll evaluate it next year. Like, you don't want to be haggling for another 6 months and then not get that increase either, right? So I think it goes to the point of like knowing your leverage at certain points. The deal that you're presented may be the best deal that you're going to get. Lock it in, move on to next year. So, but what I like to see are 3-year deals with, obviously increases each year. It's just standardization makes a lot more sense for me.
Thanks, thanks for that. One thing that Mike did mention that I get in my position routinely when physicians are frustrated with their contracts is they find it hard to find their contracts or
true.
actually review their contracts. The evergreen piece, that window that Mike talked about, where you have a kind of 60 days to make a notice that you're not renewing. The plans are not going to talk to you if you're not willing to send a termination notice in, and that starts the conversation. But if you miss that window, and again, you have to segment that by which plan is kind of providing you the most revenue in your practice. It might be Horizon, it might be Aetna in your current area, but at least know the top two payers for your practice, and kind of get that on the calendar when your renewal is, so that if you do want to make a change, you do want to argue for increased rates, that you don't get blocked out and lose a year. I mean, I've seen that many times in contract review. So let me ask, we have about 5 minutes remaining, or 3 minutes remaining. Are there any questions anyone wants to ask, or I will give you back a couple minutes of your evening? Just raise the hand if you would like. Not seeing any, so let me just take this opportunity to thank Mike for spending some time with us tonight and give us an insider view of the contracting process and how health plans approach this. I think it's vitally important for all of you that are looking to renew your contracts to be able to understand how these health plans work. And if you do have an opportunity to join an IPA or join an independent practice association of some sort that can give you a little bit more clout in the market, reach out to Mike, or reach out to one of the other groups that he has spoken about. It's a way to at least consolidate with other groups without actually selling your practice to private equity or joining a hospital. It's a nice option in the market to explore. Anyway, thanks for joining us tonight. And